Thank you all. We are still a minute early and getting our speakers situated. So please hang out for a bit and we'll start a minute or two after. Hello, Dr. Wong.
Hi, can you hear me?
I can hear you, yeah.
Oh, there we go.
And now we can see you, awesome. Folks are still filing in. We'll get started in just a minute or so, and I'll kick us off with some things. So you still got a few minutes. You can get back for that. Thank you to everyone who's still coming into the room. We're going to get started here in about a minute or so. It's just 3 o'clock, and I know Zoom takes a few minutes for folks to get connected. Twenty more seconds. And Shreya, just real quick, you don't have to admit them manually, correct? Folks are able to just join. Great, that's what I thought. Just gonna double check. Great. And there's Thaddeus. You can't hear us yet. Hey, Thaddeus.
Hey, sorry I'm late.
Oh, not at all. We have not yet started. We're actually just about to kick off right now.
Perfect.
So hello, everyone. Our goal is to have this only be about 45 minutes, maybe 50, because we know that folks like to have those extra 10 minutes in the hour. So we will just kick right off. Hello, everyone. My name is Frank Hood. I am the director of Hep B United, and I am supremely thrilled to be here today. This is our first session of a new capacity building program that Hep B United is launching, and it's one that we hope will continue for many years to come. It is the Be Informed Hep B Virtual Education Series. This is something that has been a long time coming and a lot of work across many different folks at the Hep B Foundation and Hep B United. So we're really excited today to actually have people in the room and speakers in the room and a slide deck. Everything's official with a slide deck. So we really are excited. This was really came out of a desire from many folks, public health adjacent, who wanted to have the structured environment like an Echo to learn items about hepatitis B, but without necessarily, some of the complicated CME aspects or things like that. So we decided as Hep B United to try to kind of find that balance of how we could provide really good best practices about what's happening here in hepatitis B, but in a more sort of didactic, educational way, and in a way that could be 45 minutes instead of like an hour and a half. So for those of you who don't know about hepatitis B, we are a coalition of coalitions. We started 10 years ago as a coalition co-founded by the Hepatitis B Foundation and the American Association of Pacific Islander or Pacific Community Health Associations, APCHA. And came together to create this coalition that is a coalition of coalitions. We have local, state, and national partners that each create their own or hold their own coalitions within their jurisdictions. And we come in and help bring everyone together, provide best practices and other capacity building programs as it relates to hepatitis B. And we're really excited to be here providing all of these different opportunities. If you are doing hepatitis B work on the ground and you're creating a coalition and you didn't know we existed and now do, please reach out to me. I will gladly have a half-hour call with you about how awesome we are and how we're free and how we can go and get you a lot of good information and maybe some resources. We are actively expanding membership, so please, you are working on hepatitis B and want to create a coalition or are doing so, talk to me. So that's who's hosting today. So what about the session overall? So the Be Informed, as I said, virtual education series, it will be every other month. So the third Tuesday at this time for about 45 minutes. So you can go and start putting on every other month's Tuesday at this time on the third Tuesday from here on out. And you know that we'll come with you with something from hepatitis B. We're going to be more anticipated than like Game of Thrones and Downton Abbey combined. Just look out. As I said, this is really open to folks kind of really doing any sort of work around hepatitis B, whether that is a clinician or a patient or a family member. We want everyone to be informed, and we think it's important that everyone be informed and do so in a understandable and well-regarded way. Each session will focus on a different topic. Today's session is focused on epidemiology. And next session, we'll be focusing on what the realities on the ground look like. So what our care continuum looks like, where some of the barriers are. We'll have some more information about that. As I mentioned, they're 45 minutes long. And we do want your feedback. So at the end of this, there'll be a couple of questions to fill out. Please just answer them so we can help create better programming moving forward. Additionally, if there are other questions, concerns, feedback, you're also welcome to reach out to me or Shreya directly. So today is epidemiology. Shreya is going to drop in the chat our registration link for our next session in 2 months, because we're totally on top of the game and already have that set up. So like I said, that will be looking at what hepatitis B is like kind of on the ground in a more specific sort of programmatic setting, sort of where the barriers around screening and vaccination and linkage to care might be. So we hope to see you in July. So today, this was the welcome. I've taken basically the 5 minutes. We'll then have Dr. Robert Wong talk to us about the 2021 report showing really what we like to think of as the true prevalence of hepatitis B here in the country. And being in an echo sort of format, that will be a very didactic speaker. And then we have the amazing Thaddeus Pham. Dr. Wong's also amazing. Thaddeus always has some fun intros, so this time I used amazing. He's also known as the data queen, which is why we wanted to have him on today, because his case study, he'll be talking about how Hawaii uses data to create reporting that will just blow your mind. And if it blows your mind, it'll also blow your boss's mind, other folks that you want to need convincing around hepatitis B and all that. And at the end, please pepper them with very tough, hard-hitting questions that you need answers to, so you can go and take what they talk about and incorporate it back at your facilities. So that's how the next 40 minutes or so will go. This is a webinar, so as you see, we are in attendee and panelist format. You're all on mute. You have the chat that you can chat in. You also, if you want to get us questions, please use the Q&A box for that. And we are recording the presentation, so we will have that posted later. And without further ado, I will turn it over to Dr. Robert Wong.
Great. Thanks, Frank. Thanks, Shreya, and Hep B United, Hep B Foundation for inviting me to give this didactic. I think this is really exciting, and this is going to be such a powerful initiative to really raise awareness about the importance of hepatitis B. Let me share my screen and make sure that works. There we go.
You see it?
Let me switch screens here. Great. So today, in the next 10-15 minutes or so, really, as Frank mentioned, the goal is to update the epidemiology of chronic hepatitis B in the US. And this is, I should have put the reference, but this is mostly a summary of a paper we published just last year on updating these estimates. So background, some of this, most of this, the group here probably is already familiar with. Majority of individuals with chronic Hep B in the US are primarily non-US born, given the known epi and demographics of chronic hepatitis B. Existing studies that estimate chronic Hep B prevalence that primarily use large data sets or surveillance data such as NHANES that you might be familiar with may be limited in accurately describing disease prevalence. because as we know, ethnic minorities, underserved and vulnerable populations are often not well captured or sampled in a lot of these types of data sets. And so underdiagnosis or underreporting, also due to suboptimal screening, linkage to care, also creates challenges in accurately understanding and describing Hep B epidemiology. This is a paper published about 5 years ago now. This was published in Lancet from the Polaris group, estimating the global prevalence of chronic hepatitis B, stratified by different geographic regions, as you can see up in the legend. And the main message here is to really emphasize the concerning gaps in the cascade of care. As you see here, they at that time, 2016, they estimated nearly 300 million individuals in the world with chronic hepatitis B. But bring your eyes to the third bar here and look at this big gap between the first and the third bar. Only a fraction of those with hepatitis B have been diagnosed. The other major gap identified here is you see the second bar. This was an estimate of so-called treatment eligible patients with hepatitis B. And then comparing bar 2 and bar 4, you see another important gap is the small fraction of patients who are treatment eligible that actually have received antiviral therapy. So this is on a global scale. And the Polaris group, the CDA Foundation, actually has a nice website that's constantly updated. And you see here a snapshot that I took showing data from 2016, about 10% diagnosed, 5% treated. It really emphasizes the really concerning statistics with hepatitis B globally in the US and highlights some major gaps and major need for improvements in how we manage chronic hepatitis B. So that was the estimate at that time. The most recent 2020 estimates are probably closer to 270 million. And that's due to probably improvements in new infections due to vaccination, but also, unfortunately, patients, aging population of chronic hepatitis B dying from complications such as cirrhosis and HCC liver cancer. As you can see, the World Health Organization goals by 2030 for viral hepatitis elimination are illustrated here. And as seen by the snapshot, we are far away from reaching these goals, and really highlights the immense amount of work that is needed to really get closer to these viral hepatitis elimination goals. These are data that we published, and I will be going through some of the specifics. This was published late 2021. And in our data, we looked at updated prevalence of chronic Hep B in the US. We compared it with 2009, and we updated it with data through 2018. And you can see here, we stratified it by country of birth. As expected, the vast majority of chronic Hep B individuals come from Asia Pacific regions, as well as the Americas and African regions. And we do have some so-called domestic or US-born cases, but that is, as you can see, a smaller proportion of the total Hep B populations. Based on these estimates, and this I will be going into the details of the methods, we estimated that up to 2.4 million adults have chronic hepatitis B in 2018, which is different than if you look at data specifically using NHANES. And that's because our methodology, I'm biased, but I think better captures the comprehensive nature of epidemiology in the US. This is contrasted again from the Polaris website. You see that while the US is doing a little bit better than global numbers, we still have a far way to go to really reach those WHO goals for viral hepatitis elimination. As I mentioned, this is a summary of the paper that was published a couple years ago, as you can see here, if you're interested in pulling that reference. So I'm just going to go into some details to really help us understand how we got to these numbers and why we feel strongly about the accuracy. We use systematic review and meta-analyses across country and region-specific Hep B prevalence, and we focus primarily on population-based studies. We link these to US Census data to really get an accurate extrapolation between immigration patterns and Hep B prevalence in the country of origin. We use random effects meta-analyses models, and really the goal was first to estimate non-US born individuals with chronic hepatitis B, and then we added that to US born data that is that I think can be accurately estimated from other data sets. This is just summarizing what I said. This was the overall study flow. Not going to go into a lot of details, but really you can see the rigor with which we identified these studies. We started with over 20,000 studies across 117 countries. And by whittling down inclusion and exclusion criteria, we ended up with over 1,900 papers that we reviewed in depth. And that included a total of 2,800 Hep B surface antigen prevalence studies, and included a total of 112 million subjects included. You can see some of the highlights of the study characteristics. 457 were in immigrant populations. About 2,300 were in surveys of populations from their country of origin. 21% of the surveys were completed before the 90s. And then you can see subsequently more were included in the latter part, so more recent studies that were published. Overall, 27% of the 112 million survey participants that we captured were male, 58% were female, and then some did not have sex or gender reported. So this is the big take-home message, and I will help walk us through it. On the left side of this figure, this estimates the non-US born distribution in total, not specific to US. So for example, how do you interpret this? In 2018, we estimated about 14.7 million individuals in the US emigrated from Asia. About 24.4 million emigrated from America. So that's how you interpret it. On the right side is specific for hepatitis B. So we estimated in 2018 about 870,000 individuals with hepatitis B were from Asia Pacific regions or Asia, and about 274,000 were from the Americas. And so we estimated about 1.47 million individuals in 2018 with hepatitis B were non-US born, with the region-specific distributions you can see here on the right side of the graph. Then we did a bunch of, this is kind of complex, but we did a bunch of different sensitivity analyses using different methodologies, whether it's random effects, meta-analyses. We adjusted it by different ways to capture immigration patterns and different interactions by sex. We also adopted or adapted some of the previous data based on NHANES or based on the Chronic Liver Disease Foundation publications to really give a range of what these estimates are, because they're not 100% accurate. And you can see that we did a pretty thorough job in trying to cross all the T's and dot the I's to address the potential biases that might be present in the analyses that we performed. So finally, our take home in combining the data from our foreign-born analyses combined with US-born analyses, which is primarily based on NHANES data, you can see here in 2009, the total, so this represents the total population, was about 1.75 million adults with chronic hepatitis B. And in 2018, our estimate was 1.89 million. And then if you apply the confidence intervals, it's up to 2.4 million adults with chronic hepatitis B. This is particularly relevant just to highlight, as many of you know, CDC came up with released new recommendations not too long ago that recommended Hep B screening and testing universally. This is very exciting and even more emphasizes the importance of initiatives like these to raise awareness. They recommend triple testing with surface antigen, Hep B surface antibody, and total core. And here is just to emphasize the rationale for recommending universal testing, which is very fascinating to see. It hopefully will reduce stigma, simplify. It's cost effective. Not going to go into that data, and really allows us to improve timely diagnosis and linkage to care for chronic hepatitis B patients. And this is also, I think, goes hand in hand with a recent recommendation last year that recommends nearly universal Hep B vaccination. So this is very exciting to see. Now we have testing, vaccination, and I think this will really move the field forward in terms of screening, test, diagnosis, linkage to care for Hep B patients. So really, just due to time, I want to summarize the take-home points from this Hep B study. Again, in 2018, we estimated total prevalence in US about 1.89 million, up to 2.4 million, considering confidence interval estimates. Large proportion remains undiagnosed and not linked to viral hepatitis care and treatment, which is another important aspect of the cascade of care that needs to be addressed. Recent updates in guidelines and policy changes, especially Hep B screening and near universal vaccination, is an important first step that I think will drastically improve hepatitis B care and management. But we definitely need more resources, US and globally, and programs like this with advocacy and education are important and needed to really continue to improve the Hep B cascade of care and help us move closer towards achieving the viral hepatitis elimination efforts and goals by the World Health Organization. And with that, I will stop and turn it back over to Frank.
Unmuted. Thank you very, very much for that. We're actually going to move right into Thaddeus, and then we will go into Q&A. And yes, this is being recorded for future viewing as well. And please submit your questions into the Q&A so we can dive right into those as soon as Thaddeus is done. Thaddeus, I'll turn it over to you.
Thanks, Frank. And thanks, Dr. Wong. Actually, it's so funny. I have your article printed out right next to me because I was going to update some other slides. So I really appreciate that. So hi, everyone. Thaddeus Pham, him. I'm with the Hawaii Department of Health and also Hep Free Hawaii. Frank called me the data queen. I wouldn't call myself that, but I do recognize the importance of data. So what I'll share with you is actually the efforts of myself, but also really our epidemiologist partners that we've worked with. So I'm going to share with you something we did in Hawaii because we don't have great surveillance. And that is our first ever Hep B mortality report that came out from the Department of Health. So for us, this is a novel approach, and perhaps this is something that you consider for your jurisdiction to see what you might be able to show if you don't have a robust surveillance infrastructure. So the question that I always start with for this particular presentation is, what can you do without surveillance data? Because this is something we truly had to consider in Hawaii. This is just, I'm going to read all these numbers to you now. Just kidding, I'm not. But if you just look at the highlight at the bottom, you can see that Hawaii, because of our lack of infrastructure, wasn't able to report very consistently or robustly on hepatitis B numbers for our state. So given that, knowing that we don't really have that data available, what could we do? Well, we started to look at other opportunities, and one of them was locally, we convened, as I mentioned, a group of different people with different expertise to work on a mortality report, because we're thinking there is data available, just not necessarily within our current infrastructure. So it was me and the Harm Reduction Services branch and doing coalition work, really. Our program planning epidemiologist, our HIV harm reduction epidemiologist, and then a volunteer student who is a CDC fellow. So we came together to kind of figure out how we might put forth this report. And there are a few data sources that we looked at that we considered for putting this out there. The first one is something we call Hawaii Health Matters. It's a health data warehouse specifically for Hawaii, pulling data from things like the Youth Risk Behavior Survey, the Behavior Risk Factor Surveillance System. So kind of survey-based data that's done nationally and locally. We also considered a claims database that is just being started called Laulima, and it includes most of the hospitals and long-term care facilities in Hawaii. However, we figured that, given what we needed, these weren't going to have the right data for us that would be robust enough for what we wanted to share. So we looked instead at these two data sources, which I'm going to note are publicly available and don't require like an application or anything. So one was just looking at US cancer statistics, and also CDC Wonder, which is an online mortality database that you can search as an individual using billing codes or ICD codes. So that's what we decided to use in our mortality report. So I'm going to go into a little bit of what our epidemiologists did, and I'm going to hope and pray that I'm speaking correctly, but if I misstate anything, I'm going to ask for your grace on that. But this is what they were able to do. So using CDC Wonder data, again, I'm going to just give you some screenshots. Here's the link on the upper left. But this is what it looks like. You can click on it and you can see that they've highlighted in red the data request button for 1999 to 2020. They clicked on that button, you read the agreement, of course you agree, so you can access the data and use it appropriately. And then you can start just kind of slice and dice the data and really start to look and see what you want to pull out of here. So what we found really helpful is a quick start guide for those of you who are either data folks who are not as familiar with CDC Wonder, or non-data folks who are interested in kind of playing around and seeing what you can find from this. So there's a great quick start guide here. The slides will be shared, and that's what we use to move forward. So what did we actually do with the data? Well, first we looked at research, much like Dr. Wong did. We culled the research and looked at Hep B mortality literature and looked to see what codes they used, right? If someone already did the research, why not kind of glean their knowledge, right? So these are the billing codes for ICD-10 that we use to identify when we look through mortality data. Something to note is that we looked at multiple cause of death, which is right any associated cause with death that had Hep B. Underlying cause is very specific. It's more almost like the primary cause of death. But we know if someone died, for example, of liver cancer, Hep B could still be associated with that, right? So we wanted to make sure that we capture that with the more expansive multiple cause of death. So that was one of the tips and tricks that we learned. We also adjusted the rates of mortality. So we adjusted to age distribution of the 2000 US standard population, and we expressed it per 100,000 people. Because we clicked on that agree button, right, we had to also abide by confidentiality and suppression rules for CDC Wonder. So if there were less than 10 deaths in 1 year, we would have to suppress that data and not share that. And it would be reported as an unreliable rate if there was less than 20 deaths in a year. So we had to abide by certain things if there are low numbers, basically. Finally, because we had low numbers of deaths per year, right, and because of the suppression and confidentiality rules, what we did is we combined rolling years. So we combined 3-year moving average rates so that we could have enough numbers to share in the report, which did mean that our epidemiologists, so thank you, Feng, had to run separate queries for each 3-year set. So she ended up having to run 19 queries to generate the trends for our data set, which is 2000 to 2020. So what did we find? So this is I'm just going to give you highlights of some of the findings. These are the age-adjusted rates of Hep B associated deaths per 100,000 people in Hawaii. The main thing to look at is you can see the lower kind of the blue. If you can't see colors, it's the lower trend line. That's the US rates of hepatitis B mortality or deaths. And then you can see Hawaii is noticeably higher for every single year in the 20-year span that we looked at it. Feng also noted that the national 2025 goal for elimination is at 0.37. The mortality rate should be below that 0.37, and so we are not there, and we have a lot of ways to go. So we have to reduce our mortality rates in Hawaii by 63% to reach those goals by 2025. This is something that Feng and the epidemiologists wanted to note also is on the left, you can see this is our general population in terms of percentage of people who identify as Asian or Pacific Islander in Hawaii. And then on the right, you can see these are Asian Pacific Islander people in Hawaii with Hep B associated deaths, right? So just showing that there is that disparity when we consider that 62% of people in Hawaii identify as API, but 80% of the deaths are among API people associated with Hep B. And then we look closer at this disparity, and you can see, for those of you who can't see color, the lower trend line is all residents across Hawaii who with Hep B associated deaths. And then you can see the upper trend line is API residents with Hep B associated deaths. So you can see the disparity there as well. Luckily, though, we are meeting and exceeding the goal for API people in terms of Hep B mortality, which was to go beneath 1.84 people per 100,000. So we're doing that at least. So we're proud of that. Just noting some limitations when you're working with CDC Wonder and data, death data in this particular realm is that there is no individual level data. So you're just getting aggregate numbers. So there are definitely confounders that you have to consider. So this data is imperfect, but we are seeing something, right? And that we also cannot separate out Asian Pacific Islander and Native Hawaiian people. So that's really problematic because we know there's different disparities within each of the countries of origin for our folks in Hawaii specifically. Also, underreporting is an issue. You could see here on the left, not according to one article we looked at, 19 out of 19% of people who died from hepatitis B had Hep B reported, but 81% did not when they were kind of doing record checking and stuff like that. So the underreporting is something to consider as well. And that's just a bigger view. Finally, I'm just going to note, what do you do with the data, right? I think it's really important to put data out and to make it accessible, but also you want to use it for action. And this is something we always keep in mind when we do data in Hawaii. So one of the things is this report was part and aligned with our Hep-Free 2030 plan, which is our statewide strategy to eliminate hepatitis. And so we use it for data for decision-making, but also we recognize it's useful in all the realms of our elimination strategy. So we created this report, which is very official. It comes from the Department of Health. You can see the logo there. But we also published it in our local journal so that our providers and other folks can cite it and look at it and see it as something that is relevant among their peers. And we also created a one-page infographic that summarizes the main points. And on the back of this, we actually have a letter with billing code so folks can take this directly to their provider and get tested appropriately. In addition to putting out the data in multiple report formats, we also posted it on the Department of Health website and on the Hep-Free Hawaii website. And then we were like, this is important enough where we should get some media traction. So we worked with the Department of Health to put forth a press release, again, highlighting this and the impact on our local communities and making some recommendations on what should be done. It was picked up by our local news. So you can see here our neighbor island news stuff. Our local public radio actually had a segment on it. I didn't know until someone came into work and told me that they heard about it on the radio. So really getting it out there so folks can elevate hepatitis B as an issue, but also know about the report. And this is social media. So we also worked with our Department of Health and Hep-Free Hawaii to create social media products to again highlight this and elevate this as an important issue in Hawaii. And finally, there's Feng, who's our great epidemiologist presenting. So thank you for this opportunity to present. I think talking about and sharing this, the way we did this was really helpful for folks as well to, again, raise the issue and show that this is an important issue for Hawaii. So I'm going to end with this question, not what can you do without surveillance data, but what can you do with non-surveillance data? And I think you can do a lot and show a lot of impact for your local community. So if you want to just scan this, you can do that. These will be shared with you. Here's the link, so you can click on this later. I want to thank Fenfeng, Nicole, and Risa for their great work on this. And here's the citations. And I'll turn it back to you, Frank.
That was awesome. Thank you. So we've got a couple questions. Keep sending them in. I will ask. I'll kick off with a question. I have two questions. So first, Thaddeus, this was awesome. It's incredible where you've been able to get that report. It just came out. It seemed 3 months ago. So you're going to make next year's report bigger and better and with more stuff in it, knowing you. What are you looking at to try to make sure to capture for next year?
Yeah, so actually it's interesting. So next year we're gonna focus on Hep C to elevate both, but already we've been using this in our policy making. So now we can just say two things. We can say Hawaii has higher rates of Hep B deaths than the rest of the US, and two, it affects Asian Pacific Islander people more. So we now have two solid sticky points that we can tell legislators, and this is why we need more hepatitis B services. This is why we need more hepatitis B programming. This is why we need hepatitis B elimination. So we've distilled it into those 2 points, and then we just refer back to the report if they want to see more. And then in the future, we will update it, but we want to also give it a few years to build up more data so that it's not just the same report that's updated by 1 year.
That makes a lot of sense. Thank you. And Dr. Wong, the reality on the ground around infectious disease has been very different over the last 10 years. Part of that is certainly an increase in new cases of many different infectious disease as a result of injection drug use, but also just communities having a higher focus around testing and treatment. I hope that you're all able to do this sort of prevalence work in the future. What do you hope to see between now and then change, either because that would mean the public health system has tried to solve a problem, or something that's changed that then would allow you to go and do that manuscript again, but with better data, updated data? What could you use to or what would you like to see kind of move for the next time you do this?
Yeah, no, thank you for that question. I think I put it in the wrong box, but I just want to congratulate Thaddeus and his group. This is really exciting, and it's really such a great example to see how you use big data and really translate that into state or local level decisions. So it's a really, really inspiring what you guys have been doing. And with your question, I think one of the challenges that we've seen with Epi in the US is many counties and states don't have a national Hep B surveillance program. Even we're trying to do some stuff in California and specifically in Alameda County, and luckily we have some surveillance data, but there are big gaps. But I think one thing that would be nice to see that would really help us better understand disease Epi, but also provide more guidance on accurately assessing healthcare resource needs and policy, is really having, and this is a big ask, which I know is not possible in the current landscape, but having a really national system where you can track and survey and allow us to better link hepatitis B patients into care.
Yeah, you're preaching to the choir there for sure. Thaddeus, we've gotten two questions around your program in Hawaii, both basically how vigorous is your perinatal Hep B program, and what is your program for surface antigen positive pregnant people?
Yeah, great question. So when I said we didn't have robust surveillance, I do want to clarify that we do get funding specifically for perinatal Hep B surveillance. So that is actually funded and staffed, and they do focus on that. So for in terms of Hawaii, for Hep B surface antigen pregnant women, once we get electronic labs reported to our disease outbreak control division, they will immediately follow up with the pregnant person and make sure that both that person, the family members and of course the baby get all the appropriate prophylactic that's needed and recommended. So that is in place. I want to reassure folks when generally, and that I think is funded separately from chronic disease or acute Hep B surveillance, which is why that's kind of always been there. So that is in place. And I think there was another question from Sherry I saw. So in terms of, I know that not everyone has just an epidemiologist hanging out at their house or something or in their community. So to answer Sherry's question, if you don't have access to a wonderful epidemiologist who's passionate about hepatitis, I think that you can go to your local academic center would be my recommendation. So a university or college, and see if there's an epidemiologist or stats person there who'd be interested in doing this project with perhaps a student, like a master's level student or even a doctoral level student, to put forth a report. And I think that'd be really novel, especially if they've never done it before for your jurisdiction. So I would rely on our academic partners in that instance.
I actually want to ask a similar question to Dr. Wong. So that paper showing the 2.4 million really does give, I think, the more realistic view of what's happening in this country around the prevalence. But that took a lot. And while it's fantastic on a national level, many states and localities really need to know state and locally. How can they, even if it's not like official, how could someone sort of like guesstimate or hack together a potential idea of what their risk or prevalence might be in the state if they're trying to, do the low resource public health approach?
Yeah, great question. That these kinds of efforts oftentimes take a lot of effort and a lot of coordination, and unfortunately, it requires a lot of funding to really support resources to do that. And many programs and counties and states already have limited resources. So I would say, we're trying to do something currently in California. Luckily, California has groups both at the county and at the state level that are interested and invested in really understanding, describing chronic Hep B. Those in other states may not have that kind of program. So I would recommend if someone is interested in really understanding disease epi in their region, whether it's at the county level or state level, try to identify and partner with some of your local public health folks, whether, I would probably start at the county level because those are maybe people that are easier to access based on locality, and then they can probably help connect you to people at the state level to really explore, one, what is the status of data that's available, and then two, if that can even be, or how that can be used to really provide estimates of disease prevalence. And sometimes, we've looked at this or explored this with other states. Sometimes it's not possible to get accurate estimates, and that's okay. And that's where you have to rely on other data sets or even small cohort studies and sort of extrapolate with inherent limitations using that method.
That's a great answer. Thank you. It's not fun to have to sort of hobble together things like that, but it's certainly necessary when resources require it. Well, I said that I would try to keep this to 45 minutes, and we're at 43. And so I'm going to take this last 90 seconds to reiterate a couple things. One, thank you all for attending this very first session of the Be Informed Hep B virtual education series. Very much appreciate the 60 plus of you who attended. Extra special thanks to Dr. Wong and Thaddeus. This was absolutely great. I am looking forward to the survey questions at the end of this webinar that everyone should answer, and any feedback you want to send back to me, but or to us. But I really do believe that this was just so informative to show kind of how we get the numbers we get and how we can use the numbers we use, and that kind of we all have a place in it. We all either have a place in raising awareness around surveillance and the need for that screening data to be incorporated. And then also to go and once it has happened, find ways to use it and get it to the people who need it. I am dropping in the chat our registration link again for our next session, which is July 18th. We'll be focusing on eliminating hepatitis B and what is happening on the ground. We have our fabulous president, Dr. Sherry Cohen, who will be coming in and talking, and then we will have a case study, TBD, on who it will be, but coming in and talking about how they do their programmatic work on the ground. If you had someone who wanted to learn all this great information and wasn't here, this has been recorded. Take a look at our next Hep B newsletter or on our website, and we'll have it up probably by the end of this week. We usually get those up in the last couple of days. Thaddeus, Dr. Wong, anything you want to say in the last 30 seconds?
Great program.
Awesome. Well, thank you.
Yeah.
Well, thank you all.
No, don't get mad, get data.
Yeah.
There you go.
Yeah.
Yeah, there you go.
Well, with that, everyone, please enjoy the rest of your Tuesday, and we will see you in 2 months for another 45 minutes of hardcore Hep B education. But until then, keep on keeping on.
Thank you.
everyone.
Thank you.
Have a good one.
Yeah.
Take care. Bye, everybody.
Bye.